We're talking about the intraoperative use of color Doppler ultrasound for CSF measurements and surgical guidance in Chiari 1 malformations, pharyngomalia, and tether core surgery. This is not going to be in details. This is just going to be a primer. So the machine lives in the operating room. This is not something you could do as an outpatient basis. How does the machine work? You send a burst of ultrasound beams inside the body. You listen for echoes. You decode the echoes, the signal contained in it, and you build a picture. There are different modalities. Now, first of all, the conditions in which we are measuring are far from physiologic. We're not measuring the heart in somebody with the, in the lab. We're not measuring the neck in a vascular lab. We are in an operating room. So the skull is open. We're dealing with people that obviously are not healthy, but they have pathologies, and they're under general anesthesia because it's not humane to rip somebody open without that. So we cannot use the ultrasound through the intact skull to measure all these CSF nuances. Now, everybody knows the cine MRI, and by now everybody has a doctorate degree about the advanced degrees of MRIs that the amount of information you can squeeze further. That a lot went into a lot of details, and this is a picture from the work of Dr. Iskander. Dr. Iskander relied on other engineers for that to be done. Now, you can also play some more. We did the same kind of imaging in patients with Chiari 1 malformation, supine and standing. And you have different velocities, different resistances. When you stand, the tonsils go down, they impact more, they affect the flow, and this is expected. But the cine MRI and the color Doppler ultrasound are doing the same job in two different settings. The cine MRI works as an outpatient, on an outpatient basis, and is cardiac gated. That means that you look at reality with one pair of glasses. When you use the ultrasound, you look at reality with another pair of glasses. The cine MRI is bound to fixed angles and is restricted to analyzing up and down directions. Now, this color Doppler has, again, different pros, different cons. You need the patient open, so you have to do it intraoperatively. It's more invasive, so you cannot do it on an outpatient basis, but has less limitations. It does not miss on periodisms. Like everything in the cine MRI is cardiac gated. So all those waves you were seeing were within 1 point some seconds because everything is synchronized with the heartbeat. But there are a lot of other movements that happen in the CSF. Yesterday was shown to you that you can have respiratory variations and more. And these are missed on the cine MRI because they're simply filtered out. The color Doppler ultrasound does not fix angles and can discriminate between turbulence and laminar flow. Laminar flow and turbulent flow is very, very different. Now, you have a bunch of German people in the room, you tell them to leave the room, they're going to leave in a line. You have a bunch of Italians, they'll tell them to leave the room, they're all going to crowd. Difference between laminar flow and turbulent flow. The other very important difference is that the cine MRI relies on the concept of the voxel. It was shown to you before. You have an area and you look inside, and from that you get information of the cine MRI going up and down. The problem is that you do not know what's inside that voxel. You do not know how many small vessels or medium vessels are there. The ultrasound, on the other end, allows you to see simultaneously what is what inside the volume of measurement. That said, we're going to start. Ultrasound glossary, there are different kind of imaging modalities you can get from the same machines. The BScan real time is this. You get a picture in black and white that moves over time and gives you anatomical details, like an MRI. Pulse wave Doppler is a tracing over time, expressing velocity, but contains also different information. You see the shades of gray and white over there? They're really related to power. Power is the different, velocity. One car going at 60 miles per hour. Less power, more power. One car going at 60 miles per hour and 100 cars going at the same velocity. The difference in power is how many units are going at that velocity. Another thing that you can see is that under those little peaks, you can see a dark area. That's laminar flow. While in the valleys, you can see that everything is broadened. That's more turbulent flow. Right, next, if this moves. Color coding is another modality you can paint on top, again, squeezing information and trying to build a better picture. And you can paint some red and blue on top of the B-scan real-time picture, so you have a picture of anatomy a picture of function overlapping a picture of anatomy. And the red and the blue are expressing how much is the velocity and how much are the units, particularly the cars, moving at that velocity within that frame. You put everything together, you have the color Doppler ultrasound, and you have a simultaneous evaluation. The ultrasound started in the late 70s. At the beginning, the first machines were awful to use, then they became more and more automatic with the progress of computing. In the early 80s, finally, they were first applied in neurosurgery, and as a medical student, I was one of the part of that first wave. I was so young back then. From 1983, my former chairman, because I trained once in Europe before coming to the United States, started getting in love with ultrasound, but he was completely technologically impaired. So he looked for the youngest guy on the totem pole and he said, okay, this is the machine, I bought it from the United States, now you use it. No manuals, because he lost it. It was lost in shipping or whatever. And I was thrown in just measuring. And you do it every day, and soon enough we had 1,500 cases. He was also a fanatic, so we got 15 different ultrasound machines. So every kind of rep passing by, we're sucking him in the operating room. We used something like 50 different probes, so it was very easy for me to build an experience. So enough, I was like top guy around, but I was still a medical student. We use pulse wave. We introduced the duplex in neurosurgery color Doppler for the measurement of blood vessels. I remember that I was just graduated from, I was almost graduated from residency, and I meet in Paris with this guy who was using color Doppler in Japan on arteries of the brain. We're comparing pictures with each other like the parents compare the pictures of their kids. Because we were the only ones ever doing that, so it was kind of bizarre. So over the years, because of all the nuances of the surgery related to Chiari and syringomegalia, everybody doing Chiari one malformation, syringomegalia, and telecore surgery at a certain level has used B-scan real time. Again, B-scan real time is that black and white picture showing anatomy, MRI-like pictures. During the late 90s, Dr. Mirat asked me, oh, geez, wouldn't be, since cerebrospinal fluid flow is so critical during the surgery, it wouldn't be nice to measure it. He looks at me, can you do something about it? And I say, maybe we can use color Doppler, but, and there is a but. And I solved the technological issues, and then we started doing it. Now, at TCI, we do it every day. And every step of the operation is tailored with the help of the color Doppler. The beginning was a process in which I was more enthusiastic in the pictures than Dr. Mirat was. Then as soon as we got together how much we could squeeze and how much that was going to change our life, he started becoming very passionate about it. All these are the tapes containing the information from 2001 to now. Every one of these tapes contains something like 10 different patients. You do the math. So that means every day. Up to between 20 and 100 pictures are video clips, are obtained for every single case. The routine intraoperative investigation of the cerebrospinal fluid flow is far from easy because the color Doppler ultrasound was born for the blood and not for the blood flow. That means you have to change a lot of knobs and controls on the machine. And it's not easy for somebody who's trained in medicine to get that. I'm sort of a hybrid, because I spent 2.5 years at the Polytech of my hometown doing signal processing on Doppler signals. So for me, it was more natural, but it doesn't come easy to doctors. The CSF is very different from the blood. The blood has a lot of red blood cells. The CSF is almost pure water with very small cells. That means that the ultrasound beam you send is not banging against so many obstacles, so you don't have so many echoes. So you have a very faint signal coming back. The circulation of the CSF is low velocity. The normal circulation, the normal cerebrospinal fluid flow, or at least what we considered normal in humans is around 2.5 centimeters. And very often, when you have impaired flow, you have 0.5 or 0 altogether. So it's very difficult for a machine which has been tuned for going up to 90 centimeters per second to be able to see 1 centimeter per second. Plus, the blood moves in vessels, which are tubes, while the anatomy of the CSF spaces is irregular. It's a bunch of spaces, crevices, and water passing, people passing between these tables and up and down and underneath the tables. That's what CSF does. Again, it behaves more like the Italians than the Germans. An example here is the cisterna magna. Cisterna magna is far from being a tube in which there is one only direction of flow. You see all those arrows? The reality is more complicated than that, and instead of being two-dimensional, it's three-dimensional. So instead of a road, you have a crossroad, Times Square for somebody who never saw New York City in their life. The cerebrospinal fluid, the cisterna magna, here has a complex pattern. In this location, the CSF is passively driven by arterial pulsation, venous fluctuations, respiratory activity, movements of surrounding structures, like, for example, the tonsil moving back and forth. The CSF flow does not have a heart. So it's just like a lazy guy waiting for somebody to push him out. To measure the CSF flow with a CDU, with a color Doppler unit, you need a good machine. Good machine means minimum $150,000, better $250,000. Top machines, though, are very complicated because they have a lot of settings. They were designed by engineers, so they have a lot of knobs here and there. Peak high frequency and high quality probes means $25,000 each probe. And if somebody ever drove a Ferrari in their life, it's very difficult to drive a Ferrari 12 cylinders. It's very difficult to keep it on the road. I don't have one, but same thing for these complicated probes. Brace yourself for a long learning curve to get that, and you need also to have a sort of the right stuff in you. You need to be predisposed. Not everybody can play the violin. In USA and Europe, there are different philosophies about the use of ultrasound machines. In the US, the doc relies on technicians or radiologists. So there are advantages because you have a pro doing it, but you have the blind leading the blind. Because you say, okay, I want to see the cisterna magna. You say, what? I want to, can you show me better that analysis? So the guy who knows something wants something he doesn't know from the other, and vice versa. The European docs believe in the do-it-yourself principle, but obviously it's very difficult for you to be a very good surgeon and a very good technician. I'm neither. Pros and cons of the two approaches are obvious. The CDU helps the surgeon, like I said yesterday, in doing all these steps. Practically, they help you tailoring the procedure, staying away from trouble, measuring the cerebrospinal fluid flow, etc. But this is not the topic of this. And, you use it in the OR. That means that if you use it by yourself, oh, geez, I'm going to contaminate myself. No, you put an extra pair of gloves that then you shed, and then you do like this. Probe in the head of the patient and the other on the keyboard. I feel like a rock star, but... All right. This is an example. Cisterna magna, sagittal cut like a chainsaw like this. Up is the back of the head, and the nose is down. On this side, on the left side of the picture, is the top of the head. The feet are on the opposite direction. So you see the tonsil moving up and down. Everything is labeled, so it's easy to understand. This is a B-scan real-time picture. Now, what we want to do is to restore normal anatomy, restore normal physiology. So that tonsil herniation, gone. You do the uroplasty, good. You have a big black space that now is getting painted with flow. Cerebrospinal fluid is moving, and you see all those blues and reds bursting inside the newly formed cisterna magna. This is what you want. Once you get that degree of brisky flow, you know that the syrinx, which has been forming for years within the spinal cord, is going to go, and you know that most likely the symptoms are going to improve. On the bottom right of the picture, you can see a syrinx. Obviously, the syrinx does not vanish immediately, but like Dr. Heiss showed yesterday, it takes some months. But this is a good beginning to see that. Obviously, if at the end of the surgery you're assuming there is flow, but there is nothing, it is bad. And just seeing the door pulsating is not a good sign because it could be a sign of stump flow. Example of stump flow. Try to go through like a robot through a closed door. Boom, boom, boom. You go back and forth. There is no net flow through the door. This can expand the dura, pump, 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 giving the false impression to a surgeon that you did the job and actually there is flow inside. That's a pseudo flow. If you don't measure it, you don't have it. Obviously, since it's a three-dimensional picture, you can have different bursts of flow. You can have isolated jet stream. This is just a very little primer, so I'm not going to go in the specifics. But this is just to show how the pulsations, the nuances, after a while that you look at these pictures, you can hear different voices. Human beings have voices, and if you're a Martian, everybody sounds the same, but Andrea Bocelli and me, there is a difference. Now, you can also measure that flow. So you put a little sample volume within that burst of color, and you get a tracing. And the tracings are different. There are a lot of respiratory and cardiac variations, turbulence, and all these things can be analyzed. This is for Chiari-1 malformation. Syringomegalia, another good use. You have big syrinx in the middle of the spinal cord, like Dr. Bassov was showing yesterday, and Dr. Green was showing yesterday afternoon. You have to look for the block. You have to look for the area where the cerebrospinal fluid is blocked. In this case, the snake in the lower part of the screen going from top right to bottom left is the spinal cord with the kind of a solid grayish color, while that spider web underneath the dura is post-traumatic scar. So we see where the problem is, which is not a surprise because a good CT myelogram can show you that. So you proceed with the procedure, you cone in the area of the problem thanks to the ultrasound because it helps you saying, okay, what in the MRI is on this picture is over here. So you go here, X mark the spot. Then what you do your operation, you remove the scar, you do the expanded duroplasty, and you grade yourself. Is the flow moving through that area? And you see it. You see it, you're assured, you don't pat yourself on the back because that's a jinx, but then you can also measure it again, and you can see pulsatile variations, which are cardiac gated. Here is a compressed time scale. And you can also see the respiratory variations. Peaks going down, peaks going up. Once you have this, you have the guarantee that you did the best possible job that you could do for that kind of patient, and you measure it. This is tether cord. This is a cross cut, Marie Antoinette cut at the level over here of the lower back. What you see here is a bunch of nerve roots. We're below the end of the spinal cord. And the variant of the tether cord that pathology we're dealing with is tight phylum terminale. In this case, look at the V-shaped arrangement of all these nerve roots. In the very apex of this, there is the tight phylum. This is a patient with connective tissue disorder. The phylum is very thin, which is the opposite of the usual pathology neurosurgeons describe. Because the connective tissue, the phylum is made of connective tissue, and in Ehlers-Danlos syndrome, the connective tissue is genetically defective. This is what happens after you cut the rubber band. The nerve roots relax. Now they're not anymore tight in tight spot, like a tight string, like pulling the tail of a horse, but you let the tail of the horse is happier, and everything kind of relaxes, and now more area within the spinal sac is filled by these less compressed roots. And you see the burst of blue and red. That means that now you have cerebrospinal fluid flow. Now, you cut like this. So again, chainsaw cut. And you see the tube sideways. And you see different jet streams in between the nerve roots, which were not present before because all the situation being very tense was hampering, was stopping the cerebrospinal fluid flow. All that area was stagnating. Now you see everything moving. And if you notice, there are some reds, some blues, and they're not in the same area. The jet streams in this area go in different phases. So what goes up in a certain moment is mirrored by something going down in the stream nearby. Then you measure all the different jet streams and you see different tracings. I'm not going to go into specifics, but you understand that this is different from this. So what is important? There are two messages here. One is that the color Doppler is a difficult, there are a number of messages here. The color Doppler can help measuring the cerebral spinal fluid flow, but is a difficult technique to master. The problem mainly is to tune up the machine to make the good job. Then you can have other people, once the machine is tuned up, to do it. I taught our new apprentice, Dr. Umprapun, to do it, and I taught Dr. Nishikawa, our new Japanese friend, to do it. But they do not know how to tune up the machine. So I pre-loaded these CSF-friendly patterns and commands within our machine. But if somebody has a brand new machine, it's going to take a long time to tune it up. The second one is that the color Doppler, yes, is limited by the intraoperative approach, but can see things with a different pair of glasses from the CNMRI, so can give a complementary point of view about the pathophysiology and CSF dynamics in general. And last thing for the surgeon standpoint, since we're more, Groundian simpletons, it can help us doing a better job, or at least reassures us that what we're doing is having the effect that we were hoping for, and can also help us stay out of troubles. Thanks a lot.